Dr. Erica Luce is a pediatric ophthalmologist at Texas Children's Hospital. Dr. Luce earned her undergraduate degree in chemical engineering from the University of Notre Dame. She earned her medical degree from McGovern Medical School at the University of Texas Health Science Center in Houston, where she was inducted into the Alpha Omega Alpha Honor Society and the Gold Humanism Honor Society. She completed an ophthalmology residency at Loyola University Medical Center, followed by a fellowship in pediatric ophthalmology and strabismus at Texas Children's Hospital. During her fellowship year, she was awarded the Texas Children's Hospital's Medical Staff Fellow Excellence Award. Dr. Luce believes in providing high-quality, comprehensive care to her patients and their parents. She is passionate about continuing to learn and grow as a physician by practicing in high-volume academic setting. Her clinical interests include all aspects of pediatric ophthalmology and adult strabismus, with a focus on strabismus, retinopathy of prematurity, congenital cataracts, as well as congenital glaucoma. Please welcome Dr. Erica Luce.
All right. Hi, everyone. Good afternoon, and thank you for having me. I'm Erica Luce. I'm a pediatric ophthalmologist. And so I'm going to get started here. Okay, I have no financial disclosures. So just a brief introduction. My goal today is to provide a general overview about common ophthalmology considerations that appear in HADDS and also across the pediatric population. So this is directly from the HADDS Foundation website. You might be familiar with this screen, but I think it does give a great summary of what I'm going to be talking about today. So in particular, strabismus, lazy eye, poor vision, and delayed visual maturation. So just starting from the very beginning, the first steps when evaluating children. So really, we do rely on pediatricians a lot. So initially, a child may see the pediatrician, and then the pediatrician will refer to the subspecialist if there are any concerns. Meanwhile, for pediatric eye specialists, there are two different types. So we have pediatric optometrists and pediatric ophthalmologists, depending on where you go. At Texas Children's, we do have a team of both of these specialists. Pediatric optometrists are excellent resources as well. They are really the medical specialists. They're very well trained in glasses and evaluation of these common disorders like amblyopia and strabismus. And then the pediatric ophthalmologists are surgical specialists. So if your child is following with an optometrist and surgery is in the future or a consideration, then the care is really transferred to an ophthalmologist. My goals are kind of discussion points for today. I'm going to start just by providing a general overview of how we assess vision in children. And then next, we'll talk about amblyopia, strabismus, and some other special considerations. So this is a summary of the milestones that we are checking for in visual development. At birth, the norm is for children to blink to light, and that's all that babies can do right when they're born. Then at about the age of 2 to 3 months, and that does account for prematurity, so corrected age of 2 to 3 months, we do expect some eye tracking behavior to begin, and we call that fix and follow, the ability to fix on an object and follow it around. The second milestone in that 2 to 3 month mark is keeping the eyes straight. So prior to 2 to 3 months, it's pretty normal for the eyes to kind of wander around, but at 2 to 3 months, that's when we're looking and checking if the eyes are straight. The concept of delayed visual maturation is basically exactly as it sounds, a delay in that in meeting those milestones. So often if we do see a child who's 3 months and hasn't quite hit those milestones yet, we'll see him back around the age of 6 months and see if those milestones are met by that point. And then later on, I just wanted to highlight as well that the vision can still be somewhat blurry for children. So they don't reach 20/20 vision until the age of 6 years old. So we do have some kind of norm cutoffs that we're evaluating if we're able to assess and quantify the vision in clinic. So when a patient comes in, of course, the first thing that we discuss really is the history. So asking about clues from home. I typically ask parents if the child is tracking with their eyes at home. And of course, that is for silent activities. So if there's an iPad, if it's on mute, will the child still look with both eyes at the iPad and follow it around? Reaching for small objects is also a helpful clue. We usually ask about Cheerios or little pieces of jewelry if the child is noticing those small things. And then again, clues about whether or not the eyes are staying straight. And then also if there's any observation of shaking or wandering movements. So that's called nystagmus, when the eyes kind of shake side to side, and that can be a clue that the vision is not normal. Once the patient then is in clinic and in our office, we can really get a lot of information just by watching the child come into the room. So the very first thing I typically do with both eyes open and before upsetting the child, because sometimes our exam isn't super fun, I just like to observe and see is the child keeping the eyes straight and tracking activities with both eyes open. Then once we have that kind of basic information, we can start to actually test each eye individually. And so that does include putting a patch over one eye and then seeing if the eye is moving around, fixing on objects, and then switching. That's also very helpful for trying to evaluate if there's one eye preferred over another. So sometimes we can put a patch on. The child may be really upset because we just put a patch on, but then they kind of relax and start to look at a toy. And then we might move to the other eye and the child is just terribly upset the entire time. And then that gives us a good clue that the eye, that eye is weaker. And so the vision's blurry and the child is kind of inconsolable because now with the patch on, the vision is very, very blurry. The other assessment, of course, as I've mentioned, is eye alignment. And so sometimes really we just look even at, by shining a light, it's a pretty quick test. We look right at where the light is reflecting off the surface of the eye. And if that light reflex is right in the center for both eyes, then we know the eyes are straight. Sometimes then it's off center, and that gives us a clue of either crossing or drifting. In terms of quantifying vision, so I'm going to start with some verbal testing options. So usually this chart here on the far left, that's the standard chart for adults. For children who are verbal, sometimes we'll start to use that maybe around the age of 5 or 6. It just depends on if the child knows letters or not. It's very common that they don't. And so then we do have some other options, just other shapes and kind of more fun pictures to look at to quantify the vision. Really, I'd say our gold standard is more nonverbal testing, especially for children who are able to participate in kind of matching games. So one of our favorite techniques is called HOTV matching. And we basically will just show one of those letters, either H, O, T, or V. And then we have a little map, and we kind of make it a fun game where we'll show the card and have the child point to what letter they see in the distance. And so the HOTV matching is a great option if the child's able to participate in matching. And then on the right here, I'm just showing, this is called a preferential looking test. The provider here is holding a teller acuity card. And the way it works, it's also pretty neat technology and basic technology. There's a little hole right in the middle of the card that the provider is looking for. And then there's a set of stripes, and those stripes get finer and finer, and they correspond with a visual acuity. And so what the provider will do is kind of turn the cards around. You don't want to know what side those stripes are on. And then you hold the card up and look through and see where the child ends up looking. Instinctively, if the child is paying attention to the card, then they'll look towards those stripes. Of course, this does have its limitations. It does require the child to pay attention to the card. And so sometimes we can do this once or twice, and then they're bored and no longer want to look at the card at all. So, but at least it's some way to try to quantify the vision. Okay, so now that we know some basics for how we're figuring things out, kind of cluing or piecing together the clues of vision and alignment, I'm just going to go into some of the common pathologies that we do see. So amblyopia is very common. When ophthalmologists use the words lazy eye, this is what we're typically referring to. So amblyopia is the concept of one eye not seeing as well as the other. What happens is our eyes, of course, send all the information to the brain, and then the eyes rely on the brain to actually process the vision. And so if one eye is seeing better than the other, then the brain can just ignore the weaker eye. And the problem just gets worse and worse in that the brain isn't learning vision for one eye, while the other eye that the brain likes is developing normal vision and really becoming the strong and better seeing eye. There are 3 categories for amblyopia, or 3 causes for it. One is a difference in glasses prescription. So if one eye doesn't need glasses, the other eye does. Then if the child isn't wearing glasses, then the vision can be very blurry in the one eye that would benefit from glasses, and the brain just ignores it. Eye misalignment, strabismus, is another cause. So if one eye is drifting out all the time, the brain just tunes that out. Children don't really get double vision. The brain just uses one eye and ignores the one that's misaligned. And then the most rare, least common, would be something like a congenital cataract, or anything that's blocking the visual axis. So anything that's preventing light from entering the eye and vision from developing. Okay, and then so in order to diagnose this, like I had mentioned at the very start, we do rely a lot on our pediatricians. So both pediatricians and schools, preschool and school, will perform screening exams. This is a photo screener here, and it's a pretty neat device. It basically just takes a picture or kind of looks at the child's eyes and then generates this report. And the report is an estimate of the glasses prescription and also eye alignment. And the report will basically flag either normal or abnormal result, needs a comprehensive eye exam. And so sometimes this is how we, especially a lazy eye from a difference in the glasses prescription. If the eyes are straight, it's really hard to know that any lazy eye is there. So this is a great device for catching that. And so then we do the full eye exam, and what we see with amblyopia is that there is an eye preference, or there's asymmetric vision, and then along with one of the causes of amblyopia. So then we get to the kind of challenging but critical part of treatment. So amblyopia is really the most time-sensitive thing that I'm discussing today. So it is very time-sensitive because the brain develops vision up until the age of 7 to 8 years old. And then after that, the brain's visual cortex is all set in stone. So someone who has a lazy eye that's not treated, if they find out at the age of 25 or 30, it's just a reality, and it's not something that could be treated later on. So we definitely want to be catching this for children at a young age. And then the sooner you start treatment, it's also easier to help the weaker eye catch up. So the gold standard for treatment is to do an eye patch. Of course, the gold standard is first address what is causing the amblyopia. So if it's because there's a difference in the glasses prescription, then we start with wearing glasses all the time. And then in addition to that, as you can see in this picture, we then do patching. Patching works by basically forcing the brain to use the weaker eye and to learn better vision. So patching can work very well with glasses. If the lazy eye is from a difference in the glasses prescription, And patching also works well with eye misalignment, in that it just forces the brain to spend time using that weaker eye that usually would otherwise be either drifting out or drifting in. Patching is very challenging. So if you've experienced it before, kids really don't like it because we're basically forcing them to live in a blurry world 2 hours a day until that eye does get stronger and stronger. So there are some alternatives. Atropine is an eye drop. It's a dilating eye drop. It works by basically making the vision blurry for the better seeing eye up close. So as long as the lazy eye isn't very severe, this is a good option. It's a good alternative, especially if patching is impossible or really not working out at home. And then the newest technology, again, I don't have any financial disclosures, but this is a picture from Luminopia. There are a few new kind of virtual reality headset options. Luminopia is one company, CureSight is another. And what they do is the child basically wears this virtual reality headset. They've partnered with a lot of different streaming services. So then the child can watch TV. It's 1 hour per day for 6 days a week. And the headset will display the TV show in a different manner for each eye. So the stronger eye, it has a lot of blurry images kind of in this puzzle piece. And then the weaker eye gets a nice clear image so that the child has to use the weaker eye to view the TV show and kind of fit the puzzle pieces together. So that's kind of the new and popular thing. It hasn't been compared to, Luminopia hasn't been compared to patching quite yet. So still in the process of being studied, but it's a good option as well. Okay, so then moving on to strabismus or eye misalignment. Strabismus, the most common, this here is just 2 examples of strabismus. For kids, the most common type of strabismus is horizontal. And so the picture on the left shows esotropia, where one eye is crossing in. And then the picture on the right shows exotropia, where one eye is drifting out. There are other forms of eye misalignment as well. So you can get vertical deviations too, but those are less common. In terms of causes for strabismus, so amblyopia is actually a cause also. It's a little bit of a chicken and an egg where sometimes you have amblyopia and then the eye is very blurry. And so the brain just ignores it and it drifts outward. Sometimes, as I mentioned before, strabismus can cause amblyopia. So the two can really go hand in hand. Sometimes strabismus, especially eye crossing, can happen as a result of the patient needing glasses. So there is some focusing power. And sometimes if a child needs glasses and needs that focusing power, the body will reflexively cross. And if that's the case, then the eye misalignment can actually be corrected with glasses. And then finally, what we do sometimes see is just a decompensation of fusion. So the brain really, we kind of rely on the brain all day to keep our eyes straight. And so for some children, they just don't have that ability to fuse. And so, or that ability to fuse kind of gets weak when they're tired. So the eyes might be straight when they're in a good mood or nice and energized. And then as soon as it's bedtime or nap time, if they're sick, then the eyes will just kind of relax and go wherever they want to sit. There are some other neurologic disorders as well that can cause strabismus. So cranial nerve palsy, myasthenia gravis, there's always other considerations that we're thinking about too. In terms of treatment, if amblyopia is present, then we do like to treat amblyopia first. So if one eye is very, very blurry and we were just to jump to surgery and bring the eyes together, again, as if we do surgery to straighten the eyes, we're really relying on the brain to then try to keep the eyes straight. So if one eye isn't seen as well, the brain's getting kind of poor input from that eye. The risk is a lot higher for the eyes just going back into the misaligned position that they were originally in. So if amblyopia is present, we like to strengthen and try to get both eyes seeing the same, or at least close to the same. In terms of other options, sometimes we will observe, depending on the severity, how often it's happening, and to what degree. Like I mentioned before, sometimes glasses can be beneficial. That's more so for eye crossing. Often we'll use patching. Really, again, though, patching is more for amblyopia and for ensuring that each eye is developing vision as it's supposed to. There are some eye exercises that can help with controlling the eye misalignment. Eye exercises can be used specifically, that's more for exotropia, or the eyes drifting outward. And then finally, strabismus surgery is kind of the last treatment option, but oftentimes it is the only way to really get the eyes repositioned straight. So again, treatment really is determined based on the cause and the severity. So this is, in terms of severity, it really ends up being a discussion with your provider, depending on how far the misalignment is and how often it's occurring. Okay, and then in terms of how strabismus surgery works, this is just going to be a little general overview. Of course, it is surgery, so it's a very serious decision to make. At the same time, for pediatric ophthalmologists, this is typically our most common surgery that we perform. It's very common. It's kind of our bread and butter of the specialty. So with strabismus surgery, what we're doing is working on the eye muscles. So each eye has 6 muscles to move it all around. And often we will work on both eyes in the surgery. So even if one eye is drifting out, often we'll go to both eyes and work on one muscle in each eye. Sometimes, depending on the scenario, we can work on just one eye at a time. And it is important to note too that strabismus surgery can be performed at any age. So there's not a deadline to this. Timing can, again, depend on a lot of things like the cause, the severity, but this is an option for children and for adults. So this, I liked this graphic here because it really shows that this surgery, we do have to make one incision through the conjunctiva, which is the skin of the eye, but otherwise everything else, the muscle itself is outside of the eyeball. So the eye muscle just inserts to the white part of the eye, the sclera. And so everything we're working on is outside of the eye. Our options most commonly include a weakening procedure where we basically take the muscle off and move it backwards, so it's a little bit looser. And then we do have an option of a strengthening procedure where we cut the muscle shorter and kind of pull it forward, make it a little bit tighter, and that'll strengthen the muscle. So lots of variations and options in strabismus surgery. In terms of general expectations, it is an outpatient surgery, so something that's performed that day, and then the child would leave the same day as the surgery. And then we use general anesthesia. Typically, I counsel to expect eye pain and irritation that will improve over a few days. That's highly variable across different children, but typically I'd say a few days is pretty average. I usually only use Tylenol, Motrin, ice packs, so the pain isn't extremely severe. It's mostly a irritating kind of feeling like you have sand in the eye, irritation sensation rather than a really severe pain. There can be redness. I usually counsel that redness can be present for about 6 weeks. And then in terms of the risks, so I kind of italicized it here because the most common risk is need for additional surgery. The rate of that is pretty variable depending on the case. But I typically, on average, hear about 30% is the percentage that we quote for needing additional surgery. And then the other risks are thankfully at least very, very rare, but very rare risk for infection, damage to eye structures, loss of vision, or double vision. Again, if the surgery is being done in children, double vision is very rare. Okay, and then a few other considerations. I just bring this up because HADDS is a neurodevelopmental disorder. And so in the process of the diagnosis, kind of things that may come up, often we're asked to evaluate children if there's any concern for cortical visual impairment. This is the most common cause of permanent visual impairment in children. And what it is abnormal visual responses in the setting of a normal eye exam. So as ophthalmologists, we're kind of able to evaluate what's going on in the eye itself and how the nerve looks right where when it enters the eye. But then there's this whole very complicated pathway behind the eye. And so we're really relying on the brain. It's the back part of the brain that's the visual cortex. To process the vision. And so if there's any insult to the brain or to the visual cortex, then that can impair vision, and the eye exam can remain completely normal other than the visual response. The treatment with this, of course, is to address any treatable pathology, but beyond that, if there's not a treatable if there's no treatment to be done for the visual cortex, there are some other options that I think are important to know as well. So early childhood intervention is basically therapy-based interventions at a very, very young age to help with navigating when someone does have cortical visual impairment. And then there's also some wonderful low vision options as well, low vision subspecialties. This is kind of a branch of optometry where they basically will evaluate what the visual behavior is like and then provide various tools for navigating with the vision that someone does have. Low vision is typically more beneficial kind of at an older age. So later on, once children or more teens can start to use devices and tools. Another consideration that may come up in the evaluation is elevated intracranial pressure. So sometimes, again, this is more like pre-diagnosis, but often we'll be asked to do the full eye exam just to see if there are any signs of high pressure in the head. High pressure in the head can cause headaches, nausea, vomiting, but also things like developmental delays. And so, and then the way it manifests for the eye exam is something called papilledema. It's basically just swelling of the nerves. So with this, we do the eye exam and we take a look. This is a picture of a normal nerve, and this is a picture of a swollen nerve. So if we see swollen nerves, it may help in helping with the diagnosis for any elevated intracranial pressure. All right, so I know I kind of breeze through it super quickly because I wanted to open up for some questions. I do have my email address here as well. So if anyone has a very, very, very specific question, I'm happy about your child or anything, I'm happy to help. I also, in terms of online research and trying to learn more, I usually recommend the American Association for Pediatric Ophthalmology and Strabismus. They have wonderful educational tools. And then they also have a whole database for looking up ophthalmologists in your area, pediatric ophthalmologists in your area. So I think that they're also a wonderful resource to have. But if anyone does have any questions, then I'm happy to take them now.
My daughter wears glasses at strabismus surgery at 10 months old. But I've noticed like recently off and on, I brought it up with her ophthalmologist. I noticed her eye dilations will be different, like between the two eyes sometimes. And I'm just curious, is that something that's concerning or is that something I should bring up or?
Yeah, definitely. So sometimes children or people in general can have different pupil sizes. It is highly variable in terms of if it's concerning or not. I'd say if an ophthalmologist has evaluated, then they've kind of checked off the appropriate things. But there are some disorders that can cause different pupil sizes. Usually the concerning things with a different pupil size would also have a droopy eyelid or an eye misalignment that's manifesting again, even though there's been a prior strabismus surgery. So I'd say as long as you have that checked, and then usually what I do if I see different pupil sizes, I just write down that that's present and I check, because often it'll stay and persist. So on subsequent exams, I can see, okay, the pupils look the same. They're still different, and they may just remain that way. That's a good question.
Some of these kids, we talked about this earlier today, they use tablets to communicate and other forms of technology. Does screen time, I guess that's the best way to put it, does screen time affect their eye vision? And how can we help prevent that, even though the kids need that?
Yeah, definitely. That is a great question. So in terms of the eyes themselves, there have been studies about blue light or screen time, particularly looking at blue light blocking glasses and seeing if those are helpful. There are no studies that have proven blue light blocking glasses are beneficial, or that the screen time is damaging the eyes themselves. What we have noticed is related to glasses, nearsightedness. So if a child is nearsighted, meaning they see better up close and need glasses for the distance, nearsightedness does progress with time because the eye grows. We just know, okay, the numbers in the glasses prescription are going to get worse over time. But on top of that, nearsightedness can worsen with excess near work. So for ophthalmologists, our concern with tablets and screens is really related to progression of nearsightedness. Nearsightedness, when those numbers get really high, so say someone has a glasses prescription of -10, -11, it is, those are kind of warning numbers, because then the eye can be at risk for retinal detachment. So as pediatric ophthalmologists, we're definitely trying to avoid worsening of nearsightedness. The formal APOS recommendation is, if a child is nearsighted, is to play outside for 2 hours per day. And so the theories there, that's evidence-based. There have been studies that have shown outdoor play slows the progression of nearsightedness. And the theories are really, if you're playing outside, you're kind of forced to look off in the distance. There are also theories that the sunlight, UV light, is actually better than that blue screen time light. In addition to that, there is an eye drop atropine, actually, that drop that I had shown earlier. There's a low dose form that can be used to try to slow the progression of myopia. Or nearsightedness. That's a bit more controversial because there are some studies that say it works and some studies that say it doesn't work. So I'd say in terms of screen time, especially when the screens are necessary and providing good benefit for communicating and for activities of daily living, just trying to offset it maybe with some outdoor time, playing outside. That's typically my recommendation. If nearsightedness is becoming an issue, then you can also talk with the pediatric ophthalmologist about possibly using atropine or some other intervention to try to prevent that progression. But that's a great question.
I have a question. So my daughter is 6 and has esotropia and amblyopia, which was corrected with patching, and with eye exams, she sees clearly, can answer all the questions. However, we noticed she does like to keep she looks at everything really closely, and I'd asked our doctor about it, who wasn't concerned. Kids do that. I still find it a bit bizarre, and I'm wondering how concerning that is. And actually, just to follow up on the other question too, from your answer, did I understand right that in that case, it's always better to be having them sit in front of a TV rather than having a tablet up front?
Yes. So I'll answer your second question first, but yeah, so I usually do recommend have them at least for screen time, use a TV instead of like the phone or the iPad. I guess it's kind of corresponds to your first question though. I do agree with probably with your ophthalmologist evaluation. If you give a child something small, like a phone or a tablet, for some reason, it's very common, this behavior of pulling it forward and looking really close. And that's true, not just with phones, but like toys and different things. There's kind of this habit of looking really up close. If I ever hear that, of course, I think the most important thing is checking the glasses prescription. So if they've had a full eye exam, if there is any nearsightedness, then glasses are helpful for wear the glasses, hold things further away. We kind of have confirmed that with the glasses, the vision's good. Otherwise though, say someone is not nearsighted and they're doing that, then glasses wouldn't help. I don't know if so basically it's a little bit challenging because if there's no nearsightedness, there's not anything to be done other than just kind of encouraging your child, okay, let's hold it a little further back. It's not necessarily damaging to the eyes, but it's definitely a very common habit that we see where kids will just go boom and really focus hard up close.
And sorry, just a very quick, and the bigger screen in terms of like, even if you're holding something close, like a bigger iPad is better than a small phone as a general rule, or does that not make a difference? It's just literally just an issue of distance.
Yeah, it doesn't make a difference, the size, more just the distance. Yeah, kind of trying to step away is helpful. But as long as nearsightedness has been ruled out, there's not really another intervention or another eye concern to be addressed. Mm-hmm. Mm-hmm.
Okay, yeah, I have a question. Two questions actually. One, like many of the other kids, my daughter had several strabismus surgeries. If the eyes are not perfectly aligned, let's say after the surgery, what is the percentage that they still have binocular vision or not, I guess? That's my first question. My second question, you had mentioned some stuff about vision exercises, and I'm curious what your opinion is on things such as like vision therapy for after the strabismus surgery, trying to get the eyes to work together again, those kinds of things.
Definitely. Yeah. So great question for the binocular vision. It's very case dependent. So binocular vision, if a child has crossing early on, usually binocular vision is poor. So when we test how the child's using both eyes together, the results can be poor. Usually if it's eye drifting, then even if after the surgery, there's a little residual misalignment, when we actually test and kind of force them to bring the eyes together and look at little 3D, very fine 3D, they can test very, very well. So I'd say that the chances of binocular vision are better if that initial misalignment wasn't a drifting. And even and then after the surgery, chances of binocular vision really depend on how well the child's controlling it. So sometimes we'll see that the eye drifts out maybe 30% of the day, but when they're in clinic and kind of on high alert at the doctor's office doing the test with both eyes straight, they could still perceive and use both eyes together very well. That was the first question. And then the second one was vision therapy. Yeah. So, yeah, I think eye exercises, I'll use eye exercises sometimes for eye drifting. If a child is able to keep the eye straight, maybe most of the day, and then it drifts at nighttime or when they're tired, I will do some just kind of near work exercises. It's mostly just trying to fine tune the control or trying to improve the child's ability to control the eye misalignment. In terms of vision therapy, I usually recommend if the if the vision, if the eye misalignment is severe, meaning it's happening more than 30% of the day, it's very prominent. Typically, surgery is ultimately needed to fix that. There is kind of a difference, though, if you ask an optometrist or like a vision therapy specialist and an ophthalmologist. Ophthalmologists, we aren't really trained at all in vision therapy. So I think we often say, oh, no, it doesn't work. It's not evidence-based, but we also haven't trained or learned it. I think it's a great option for right after surgery. Usually, if I have a patient who's interested in vision therapy, say they've tried it in the past and I'm going to do surgery, they'll ask, should I restart vision therapy right after? And I say, yeah, go for it. So I think it's just added support, since we do know that with strabismus surgery, there's that risk of the eyes being misaligned afterwards. So it's helpful. You probably need that first surgery to bring things together, but helpful for trying to then maintain the eyes straight.
So with our son, his hypotonia and his ataxia are, they progress during the day. So at 8 o'clock in the morning, he's working really, really hard to keep his motion smooth and to keep his gait well with his walking. And so he's most successful in achieving that at 8 o'clock in the morning. At 6 o'clock at night, it's a different situation altogether. He's exhausted. His eyes are half open. He's shaking. He's got less control. He's less smooth with his motion. So we feel like it might be impacting his vision. And so with his strabismus, it might be more pronounced at say 9 o'clock at night than 9 o'clock in the morning. If that's the case, is that something you see with HADDS kids? And then secondly, if that's the case, when do you schedule your optometry appointment? What time of the day? Do you want to show it exaggerated, or do you want to show it fresh in the morning?
Yeah, that's a great question. So I would say that phenomenon is very common in terms, not just in HADDS, but across strabismus. So people do have kind of different trigger times. Sometimes it's right in the morning. Like I kind of think of night owls who don't really want to wake up at 7 a.m. So the child comes in at 8 a.m. and is totally exhausted, still kind of in zombie mode. So sometimes it's the morning. But when children are tired or fatigued, then that eye misalignment can be much more exaggerated. I do usually recommend taking pictures. So with my parents often say, oh, take some pictures when it's really at its worst, because sometimes I will see children in the clinic and they're on high alert and they're really focused and the eye misalignment looks totally fine. And so seeing the pictures can be helpful. A lot of it is just your report too of what's going on. So we kind of acknowledge or know that kids are on high alert in the doctor's office, so they might be controlling it better. And so we really rely on your history or your report of what is going on. The other thing that's helpful, if you do bring your child in when they're really awake and alert, we do have exam techniques for getting the brain to totally relax and stop fusing. So even if they're on high alert, it's okay. It's actually kind of helpful to bring them when the child is feeling good and happy and able to look at toys instead of kind of in that meltdown mode, because we can bring out the full eye misalignment in the clinic.
Hi, I had two questions as well. You mentioned cortical visual impairment, and my son's diagnosed with that. Is that something that is more common with HADDS, or?
So to be honest, I'm not sure if it's more common in HADDS or not, like rate wise. I tried to kind of research that and look that up. I almost feel like we have some other resources here who might know that even better, kind of HADDS specific. But when I was talking to Mallory about the presentation, I did, that was kind of one of the things to discuss. I think it does kind of make sense with a neurodevelopmental disorder. This is something that's on our mind as ophthalmologists. especially if the eye exam is normal. Mhm.
Thanks. And then my other question is about strabismus. So our son has strabismus, but kind of uses both eyes, like it goes back and forth, and he can use both eyes equally as well. So at that point, is there an advantage to surgery other than it just like, is it going to improve his vision to have surgery, or is it more just kind of cosmetic at that point?
Yeah, that's a great question too. So when it gets to the point where amblyopia is not a concern, so let's say the eyes are drifting out and you see that the eyes are alternating using one eye equally to the other, we're not in a rush anymore. So I usually just have a conversation then at that point. Sometimes, if your child's happy, functioning well day to day, it's not a rush to go into surgery, especially because there's this risk of, well, once surgery starts, maybe the eyes will be straight for a while and then they might drift right back out and we're kind of back to where we started. So I do think it's a bit of a conversation. There are studies that show that after an eye alignment surgery, especially these studies are more like teen age, factors like mood, anxiety, coordination can improve. So there are definitely functional benefits to it. But if a child isn't demonstrating like poor mood, anxiety, difficulty with coordination, if all the functioning is going well, I think it's something that can be weighted on, basically. Yeah.
So my daughter has been seen by ophthalmology and they've told us 3 times now that her eyes are fine. But everybody else that have seen her pediatrician, the geneticist, they all see misalignment. But every time we take her, take her to the eye doctor, they tell us that they don't see it. So what do we do in that case?
Yes, that's a great question. That can happen, definitely. When we call that kind of pseudostrabismus, where the eyes can appear the way that the eye structure is. Sometimes the eyes appear in or they appear out. And then when we do our testing, what we're looking at is kind of, well, how is the patient using the eyes? So if I cover this eye, is the eye moving in or is it just staying right where it is? And then if I switch over to this eye, is it staying right where it is straight or is it moving? So we kind of have these fine techniques for seeing. So sometimes a patient will walk in and I see this and I'm thinking, oh yeah, there's going to be an eye misalignment. It looks that way. But then when I do those tests, I don't see any movement. So the fixing point, like this eye looking straight ahead, it's actually positioned that way. And this eye looking straight ahead, it's positioned that way. So if we were to do an eye muscle surgery to bring things in, then for the patient, the vision perception there is actually crossed. This is rare. So I do think you're doing all the right things in terms of going to the ophthalmologist. I would say kind of serial evaluations to confirm that that's truly the case, that there's this pseudostrabismus going on, especially if at home you're still seeing that there's this eye misalignment. I typically recommend, sometimes I'll say, let's check back in 3 months, then 6 months. But I'd say, if you go to 2 or 3 providers and they're all agreeing with that, it is hard to trust. That it's definitely kind of a trusting process. But at that point, at least you have multiple opinions and you kind of know, okay, this is that rare case of pseudostrabismus. Mm-hmm.